Good evening, everyone, and thank you for joining us and spending part of your evening learning about CAMBRA. We're really excited tonight to spend some time talking about CAMBRA for the pediatric and orthodontic patient. Before we get started, just a few housekeeping items. First, you are all muted, so we can't hear any comments or questions verbally. Second, please make sure to type questions into the questions box at the right-hand side of your screen. At the end of the presentation, we'll have about 15 minutes to answer questions. We'll do our best to get through as many as possible. Any questions we don't have time for will be addressed by email, and we also offer one-on-one webinars for practices interested in learning more. With that, I'd like to go ahead and introduce Dr. Kim Cooch, CEO and founder of Oral Biotech and the CariFree system. He's the world's leading authority on ATP as it relates to caries risk assessment. Dr. Cooch has been successfully practicing dentistry for over 35 years, still practicing 3 days a week here in Albany, Oregon. He has a huge vision for curing dental caries, and it continues to motivate him in the research he's leading to improve caries diagnosis and treatment. I know we have a lot to cover tonight, so with that, Dr. Cooch, take it away.
All right. Hey, thank you, Janelle, and welcome everybody tonight. I'm excited about tonight's program as well. We've got a lot of material to cover here on pediatric dentistry and orthodontic care, so let's get started. One of the things that I wanted to start with tonight right out of the gate is this study was published back in 2010, and of the 291 major diseases in the world that afflict human beings, dental caries is #1. And we're pretty much, that's a #1 disease in almost all age brackets in virtually every country in the world. So as we look at the burden of disease for human beings around the planet, dental caries is #1, and it's growing, and particularly growing in third world countries, but it's also growing in our young population here in the United States as well. And that's really the group that we're going to talk about tonight. You know, how do we deal and address that for our youngest patients? You know, one of the things I like to teach is I like to simplify this. When I first started with caries risk assessment and caries management 15 years ago, we made it very complicated. And what I learned over time was that we needed to simplify this and look for patterns of the disease, and so that we could begin to identify in our patients, like right away, you know, what's happening for this patient, and then logically know right where we're going to go with the treatment strategies. They're going to target those risk factors individually that patient has. So one of the things that I've taught in the past has been using the concept of the usual suspects. And we started with, you know, mutans, streptococci, and lactobacillus, which, you know, when I was in dental school over 35 years ago, that was the basis of the disease of dental caries. I mean, if you had high levels of mutans, streptococci, and lactobacillus, you had this disease, and if you didn't, you didn't have the disease. But really today we look at the biofilm itself, and it's really more of a pattern of patients. It's really bacteria. There's been over like 54 different species have been identified now that play a role in dental caries. 40% of our children don't even have, that have severe early childhood caries, don't even have mutans, streptococci in their mouth. So we know that this disease is a lot more complicated. It's more than one disease. So when I see a pattern, it's either they have too much bacterial load just in total in their mouth, or they've got, you know, the wrong bacteria behaving badly. And one of the things that we know when we take that and extend it and to look at children is that most of those bacteria in the studies, there's a high correlation to the bacteria between the mother and the child, or let's say the primary caregiver and the child, you know, if that doesn't happen to be the mother. But it's like we inherit our bacteria primarily from our mother very early in life. And the next pattern that we look for typically is diet. And the typical patterns with dietary risk for dental caries is they're either just have too much sugar in their diet, and that's basically true for almost all Americans now, or they're eating too frequently. And, you know, that really relates to the Stefan curve and the pH dropping in the mouth and snacking and continuing to, you know, provide or create a low pH environment, you know, for those bacteria. And one of the issues that certainly for children is, like particularly young children, is nursing, being able to nurse at, you know, at will, or have a bottle, you know, basically at their disposal at any point in time, certainly increases their risk. Saliva is a huge risk. I think for our older population, primarily we think about patients that have hyposalivation or xerostomach for one reason or another. The same is true for children. Dental caries is the #1 disease of children in the United States, followed by #2, which is asthma. And if you think about using antihistamines, what does that do? Well, it dries out your mouth as well. So that's one of the side effects. Also, ADHD and any of those other medications that these children could be taking certainly lead to medication-induced xerostomia or hyposalivation as well. So really, we talk about children. We're going to look at the medications. And then in the last 4 years, there have been, I think, 11 papers published now, major papers published identifying different genes that relate specifically to dental caries risk. And one of the things that we can add here, certainly on children, we know that there's a tremendous amount of research that indicates the socioeconomic status is a risk factor as well. So patients that are low socioeconomic stratification are at higher risk for dental caries. In fact, the lowest, socioeconomic patients that you have in your practice are the highest risk. And some of that has to do with culture, education, access to care. There's a lot of different issues around that, but certainly that's one that there's a lot of data on. And at the end of the day, this all yet still comes back to pH. Dental caries is a pH-driven disease. It's bacterially produced. Prolonged periods of low pH would cause net mineral loss from the teeth. So, but if you can just start to think in terms of patterns, like when we look at children, what kind of patterns do we see in terms of the decay? And, how does that relate to what their risk factors are then, and how are we going to create a strategic plan for them? If we look at the current biofilm disease model, we know that it consists of multiple pathogens. We know there are some systemic effects as well from the bacteria that cause dental caries, and we know that certainly there are hereditary components at this point in time. Some of the more recent papers that have been published, this is Ann Tanner's group at the Forsyth Institute at Harvard a couple of years ago, identified Scardovia wigsii as a common pathogen in children that had severe early childhood caries, and it was even present on those patients when they had no mutant streptococci at all. So certainly we've added to that Slackia exigua. Again, her group added the same year Slackia exigua as yet another cariogenic pathogen, and for the first time I saw another researcher start to identify patterns. And one of the things that I liked best about this paper was her team identified the data on these children tended to break into one of two groups. They either had kind of a bacterial issue or they had a dietary issue. And so again, that's really consistent with the concept that I use in terms of looking at pattern recognition and talking about the usual suspects. So, they really children break into, more often than not, bacterial issues or dietary issues. And then, of course, Diana Wolf's group last year identified Propionibacteria acidifaciens. This is the most recent cariogenic pathogen that's been identified. And they looked at 28 high caries risk individuals and then 26 caries-free individuals, and they did a panel, a DNA checkerboard of 41 different bacterial species, and the only one that correlated to the high caries risk patients was the Propionibacteria. So, we just continue to add additional pathogens, and it continues to complicate, the picture for us. And certainly we know that there are systemic effects. I'm not going to go through any of those papers tonight, but there's I don't even know how many papers I have now, but there's a bunch that identify and continuing to build the picture between bacteria that cause dental caries and other systemic effects, particularly in the cardiovascular system. We know that there are a lot of different genetic predispositions for dental caries, and a lot of these have been published just in the last 4 years, but certainly the TAS2R38 gene. Those kids are called super tasters. They're very sensitive to phenols and bitter tastes that are found in a lot of green vegetables. We also know that the TAS1R2 gene for sweet taste buds, those kids prefer to eat sweet things when given an opportunity. So we know that things like taste influence caries risk. There have been a number of other genetic factors that, that have been reported. I won't go through all of those yet tonight. This, I think, is a very significant paper from last year. They did a genome-wide association study. They looked at about, I think it was 975 patients. They did a panel of about 500,000 gene sites, and they found there were like 10 major associations between genes and the dental caries incidence. It also broke into geographic patterns of decay, and this was the Lysyl-2 gene. It produces a geographic pattern of decay in the mouth that only affects the mandibular incisors. And this was a patient of mine that the only decay in her mouth was on her mandibular incisors. And then also the AGAP1 gene, which affects tooth development. And on another paper from the same study, then the same group of data, they identified that certainly that gene is involved potentially with tooth development. This was a 14-year-old patient in my practice that I saw as a new patient. She already had 17 crowns on her permanent teeth. She's 14 years old. She needed 4 more crowns. And, she has 2 root canals. And you stop and ask the mother, has anybody talked to you about what's causing this problem, or has anybody tried to identify what's going on here? The answer is no. We just kept getting told that she needed another crown, another crown, another crown. And, that's a very frustrating position for a parent to be in. I don't understand why my child has, is only 14 years old and has 17 crowns on her teeth. Most 14-year-olds, maybe have had a few cavities, but we see a lot of, children in that generation that have no decay at all. So we start to look for other sources of risk or things that are causing that disease. CAMBRA then, or Caries Management by Risk Assessment, a term coined by Doug Young and John Featherstone, really then takes the leap forward to say, let's stop and look at what's causing the disease rather than just trying to figure out how many cavities they have and where they're located and what we're going to fill them with. And if we look at really caries risk assessment then, and there have been a number of papers published on different risk assessment forms, studies and validation studies on different risk assessment forms, particularly on children. I would tell you that the sensitivity and specificity of those forms is still a challenge for us. But again, we have to start someplace, and the fact that maybe our forms and our questions and things aren't perfect doesn't mean that we should wait until we have a perfect solution for that. In this paper that was published last year, the baseline caries prevalence was the most accurate single predictor in all age groups in this study. And I think that that's certainly been true for a very long time. That's not a new piece of information. When we look at predictive factors for dental caries, particularly in kids, their previous caries experience tends to be one of the most significant factors in terms of its predictive value. When we look at, other risk factors, we need to take that into consideration, but certainly this is probably one of the most important things statistically that we've identified. This was at the National University of Singapore, and they reported this last year as well. They had developed a caries risk assessment tool, a form, and the combined sensitivity and specificity was greater than 160%, which is really the gold standard when we get to medicine and we're looking at sensitivity and specificity of different diagnostic tests. You really need to get to 160% to have that really be a valid test, although many of our diagnostic tests that we use in medicine don't even come close to approaching 160%. But that's kind of the standard. And they actually created that standard on children, and utilizing on children. They also utilized bacterial cultures in addition to the risk assessment form to reach that threshold. So, there are a number of different caries risk assessment approaches. There are forms available from the ADA, from the AAPD. Certainly CariFree has a form for children. We'll look at that tonight. The Cariogram was developed at Malmö University in Sweden. It's available online. This study indicated that, it worked pretty well on predicting children in the very low risk group, as predicted by the Cariogram, didn't develop any new cavities, and then the higher risk kids at baseline developed a higher number of new carious lesions over a period of time in the study. On the Cariogram, it's like any of the other risk assessment forms. Again, it looks at those different risk factors and then tries to take that data and add some predictive value to, is this patient going to be at higher risk for additional cavities? Do we need to take additional measures or not? And that's really the whole basis of risk assessment, is we're trying to identify the patients that are at risk so that we can provide some intervention for that to reduce their risk going forward over time. And then here was another paper that was just published earlier this year, and we get back to, again, the clinician's accuracy in predicting the caries risk during routine practice was similar to the levels reported in research settings that simulated patient care. The accuracy was acceptable in patients that had prior caries experience. So again, if they had baseline caries experience, that was predictive of future caries experience, but they were poor. The clinicians in the study were not very good at predicting, taking a healthy child and saying whether or not they're going to be healthy going forward or whether they're going to be at risk for decay. So again, that caries experience in those children tends to be, one of the factors that, certainly a primary factor as you try and predict what's going to happen for that patient. We try to take caries management and simplify it. Try and break it down to its basic elements. And number one, you need a risk assessment form. 2, you go to diagnosis, and 3, you go to a prescription. That creates your strategies. The whole point of the risk assessment form is not to find out whether or not they're high risk. In my mind, the whole goal of the risk assessment form is to figure out why they're at high risk. I don't care how many cavities they have or how many cavities they're going to get. I want to know what's causing those cavities so I can help that patient identify and understand that and then develop some strategies to prevent that from happening or modify that going forward. So when I look at the caries risk assessment for the 0 to 5-year-old children, we start, again, as we do with our adults, we start with these behavioral questions. Would you like a free assessment? Would you like to talk about it? If needed, would you be willing to modify or discuss your children's dietary habits? And then you get down to the risk factors, and again, these are the highest in declining order, the highest odds ratios. Plaque buildup, that's bacterial load. Are they taking medications? Do they have, and this comes from a lot of other research, but does the patient see a dentist regularly? Do they have a dental home? Are they special needs? Do they continuously sip? Or, again, that's that whole snacking concept. And do any of these other health concerns apply to your child? Asthma, obviously that would be the big one in that group. And just looking at the patient, do they appear to have a dry mouth? Are there any orthodontic type appliances present? And we're going to talk about orthodontic appliances after we get done just discussing adolescents here tonight, and kind of look at the most current research there and talk about strategic or therapeutic strategies for the orthodontic patient with fixed appliances in your practice. And then, we look at the disease indicators, and one of the disease indicators we have to continue to take into consideration is the mother or the primary caregiver. Do they have active dental caries? Because the primary caregiver plays such an important role in terms of the biofilm and development of that in the child. And also, I would have to say, the behavioral environment as well in terms of diet and, oral hygiene, et cetera. And then the rest of these are then kind of the same as they are for adults. Do you see cavities? If you see, if those first 4 incisors erupt and you're looking at the 4 maxillary incisors and you see decay on the facial of those teeth, you've got a severe early childhood caries on an 18 to 24-month-old kid. So just lifting the lip and looking, you see decay, we've got a problem. If you see plaque buildup on those teeth, we've certainly got a high risk child. Radiographic radiolucencies, you may not even be taking radiographs on a child until they're like 3 or 4 years old. New active white spot lesions, we talked about active white spot lesions are dull when you blow air on them. Non-active or inactive white spot lesions are shiny. And then, the decay history, and that goes right back to the research that we just looked at. Do they have a previous history of dental caries? Because if they do, that's probably an important factor going forward in terms of prediction of future lesions as well. And then, again, you just make a professional assessment here. Are the risk factors a concern? Are the disease indicators of concern? Are these things that you need to discuss with the parent, the patient, and the parent, and start talking about strategies? And these really then just drop into risk identification, low, moderate, or high risk. And then we have on the children, we have the biofilm challenge is optional, although I would tell you that I use it. I screen every patient in my practice once a year. So I use that, and I use that as a baseline so I know what the bacterial load looks like, and I also use that as a baseline to determine whether or not this is a patient that would benefit from antimicrobial therapy, and we've discussed that in a number of previous webinars. So if we look at that biometric, the ATP bioluminescence, and look at how it relates or correlates then to dental caries, the thing that we know, the reason that we use this technology, the one thing that we know is that acidogenic acidiuric bacteria are able to maintain intracellular neutrality along with 4 basic adaptive mechanisms, but the primary one is that they have a hydrogen ion pump, and they're able to pump those acid ions. They could be in an acidic environment, extremely acidic environment, but they can pump those acid ions out of their cell and maintain neutrality while they're in this harsh acidic environment. The only problem with that is it uses up a tremendous amount of ATP. So the whole basis behind this is knowing that if you've got a biofilm that's highly active or has a high number of acidiuric bacteria, they're going to use a tremendous amount of, there's going to be a lot of ATP present in that biofilm. So either you've got an abundance or too much bacteria, or you've got a really active biofilm, both of which are high risk factors for dental caries. So this correlates quite well. Of all of the biometrics that I've worked with, this correlates the best, and it's easiest and the least expensive, has the best predictive value. So studies that we started with early on at OHSU, with Kurt Machida and Tom Meyer in the microbiology department there, and then also graduate residents. You know, they started collecting data from children, and what they found was that it correlated very high to total oral bacteria, correlated very high to oral streptococci, and including mutant streptococci, and their conclusion was it could be used as a potential assessment tool for oral hygiene and caries risk in children. Garrett Hallett then also did a study. This was at Griffith University in Queensland, Australia. This was a few years ago. It was published, but again, he looked at basically 292 children, and they looked at different caries indices and bacterial cultures, and they went through all of the biometrics available, and the only thing that was at baseline that was predictive of their caries experience was the ATP bioluminescence score. So we know that in a large clinical trial that this was highly predictive. Now the interesting thing was they followed these patients for a matter of 3 years, and what they found was that the baseline, and they provided intervention during that 3 years. And one of the challenges that we have is we don't have a biometric period that is predictive of 2 years down the road of what their caries experience is going to be like. So it's like it correlates well to their current experience. How predictive is it? That's where we lose ground on every biometric, and particularly if you're going to provide intervention in the meantime, that alters the nature and the course of the disease. So that becomes a challenge for us to take something and say, oh, you have a high score, you're going to be develop a lot of cavities in 2 years with it, you know, with or without treatment, and that may or may not be the case. So, but that's true for all biometrics that we have, and like I say, the best indicator that we have for future disease is previous disease, but again, I'm using the ATP to establish a baseline, look at bacterial load, and then determine whether or not that patient is a candidate for antimicrobial therapy. So I thought, you know, I report positive and negative outcomes. You know, I think that we need to look at all of the research, and we need to come up with the clearest path and the most logical treatment or result of that. Caries diagnosis then is step number 2 in this process, and you take all of your data. You take your known history of the patient, the caries risk assessment form, the biometric if you use it, your oral clinical examination, radiographs if you've taken them, and you take all of that data, and then you decide, is this patient, you know, that's really the bottom, the summary is the bottom line, is this patient low, moderate, or high risk for dental caries? And the ADA back in 2006 kind of gave us the guidelines, and published in a special supplement of the August ADA Journal, 2006, and it was on basically guidelines of fluoride use, in-office professional fluoride use. but they established these categories: low caries risk for all age groups, no incipient or cavitated primary or secondary lesions in the past 3 years, and no risk factors. Very few patients are going to meet all of those criteria. Moderate caries risk, if they're younger than 6 years old, there's no lesions in the past 3 years, but have at least one risk factor. That changes for patients over the age of 6, and again, patients under the age of 6 for high caries risk, any of the following: any lesion in the past 3 years, multiple risk factors, low socioeconomic status, suboptimal fluoride exposure, and xerostomia. I prefer the term hyposalivation, but again, you get the point. So we have guidelines on what we use, and I think these are probably, these come from the ADA Council on Scientific Affairs. I think they're the best guidelines for us to use. The people on that council look at all of the data and all of the available research and make the best conclusions. So these are guidelines I think that I would encourage you to follow. Number 3, then we prescribe. What are we going to do about it? And here I like to break this again, and I can remember 3 things, so I like to break it into groups of 3. Number 1, reparative strategies. That includes remineralization and restoration. We still have to drill and fill those cavities or those lesions. Number 2 is therapeutic strategies. And here we've got antimicrobial, maybe xylitol, pH strategies, remineralization strategies as well. And then you've got behavioral. And in the behavioral, I really think you've got modifiable behavioral patterns like oral hygiene and diet habits, and then you've got non-modifiable. They could either be on medications or they could be special needs. So I sit and think about the patient. How are we going to treat this patient? And I think, in my mind, I think, what are we going to do reparative? What do we need to do in terms of therapeutic? And what kind of behavioral issues? And when we get into behavioral issues, we're really going to talk about wellness coaching. So let's look at some of these things tonight. And I thought I threw in a little research that I came across as I was preparing this webinar, and I thought some things were pretty interesting. I thought this was interesting. It was they looked at 8 cross-sectional studies from 1960 to 2011, looking at the issue. The question is crowding. Does crowding increase caries risk for a patient? Does it have any influence at all? And the results were from this examination of these 8 different cross-sectional studies was there was no consensus. There was really no randomized controlled trials and longitudinal studies that confirmed or refuted. About half of them said, yeah, it might slightly increase. About half of them said, nah, it doesn't really, maybe even decrease the risk. So in terms of crowding, and that could really be an orthodontic question for us tonight, is crowding going to increase the risk for dental caries? And we don't have data that says yes or no. So, what I take away from that is the answer is probably no, but it's probably an individual thing for the patient. For some patients it may increase their risk. But there are other risk factors, other cofactors that go into that for that patient. And for some patients it may not be an issue at all. I thought this was a very interesting paper. This one was just published in the Caries Research Journal. And I think certainly my understanding has been for a long time that the risk for occlusal lipid and fissure lesions, primarily in molars, the risk has been because it's an anatomical defect of that fissure, and that's a weak link, and so that's why we use pit and fissure sealants, and that's but it's an anatomical situation, and the data clearly, this was a review and looked at a large number of studies, and the data was clear that that really is not a factor at all. The real factors in determining whether or not an occlusal fissure is at risk for dental caries tends to be how long was it in eruption. So like a slow or arrested eruption phase combined with no occlusal function on the surface, which would provide natural cleansing of that surface of debris. Those were the 2 things that correlated most strongly to a risk for a carious lesion in the fissure. So the concept of the fissure itself being at risk, really the challenge is how long is that eruption cycle for that tooth, and how long is it out of occlusion before it erupts into occlusion. So I think we need to be really mindful of that, particularly in our young patients, as we're watching mostly those second molars, permanent second molars that are erupting quite slowly, and looking at, can we get a a glass ionomer sealant on the top of that tooth, even though it may be partially covered by gum tissue. Would that be a good idea for this patient as a kind of an intermediate intervention? So things to consider. But I thought it was really interesting because it really kind of changed the paradigm for me on, why do we have this risk of occlusal lesions? And if you look at geographically in the mouth, risk by tooth and by surface for dental caries, the mandibular and the maxillary first molar occlusal surfaces are the highest at risk in the entire mouth. So those are things that I think, just be mindful of that as you've got children in your practice and their teeth, their permanent molars are erupting. I think take extra precaution, particularly in your high caries risk patients, to make sure that we're doing everything that we can. Even if the sealant isn't perfect, let's use glass ionomer and let's get something on there to start with and see if we can just protect that surface while that tooth is going through maybe a slow eruption phase. When we look at therapeutic issues, and I kind of skipped over restorative issues or strategies, I think we're all pretty much on board with how to restore caries lesions at this point in time. I think certainly we know that glass ionomers or resin-modified glass ionomers are certainly standard of practice in treating, primary teeth. Whether you use amalgam or composite on permanent teeth, I think those are questions that you need to resolve, answer for yourself, decisions that you need to make clinically. And then there was a paper published, I don't think I included it in this webinar, but like a 97% success rate on stainless steel crowns on patients that had that were at high caries risk. So I mean, there's still an indication to use, I think, restorative procedures like that. We don't have time tonight to get into questions of like silver nitrate or antimicrobial strategies using silver ion, silver amine fluoride, something like that. So I won't discuss that tonight, but again, those are things that we'll probably look at in a future webinar. Therapeutics, we talk about pH neutralization, antibacterial or antimicrobial strategies. Again, fluoride as it aids in remineralization and inhibits acid production. Xylitol, we know, reduces growth and acid production of the bacteria. And then remineralization in terms of adding some calcium phosphate to the equation, and you know that I advocate using nanoparticles of hydroxyapatite for that. One of the always for high-risk caries children is a fluoride varnish every 3 months. And I mean, that's just an always. Whether they're under the age of 5, whether the 6 and older, whether they have orthodontic appliance, fixed orthodontic appliances on, this is the best outcome. The best data that we can report is fluoride varnish every 3 months, and so that's just an always. There have been a tremendous amount of papers on fluoride varnish in children and the benefit, even on primary teeth, even on occlusal fissures. So there's a tremendous amount of information there. Now, we don't have a tremendous amount of information on studies with data on adults, but we extrapolate that and use, obviously, fluoride varnish on our adults as well. But all the data is really strong on children. So it substantially reduces the caries incidence. So that's, of all the things that we could do, that's probably number one. And this was a study just looking at children brushing their teeth with fluoride toothpaste and consuming fluoridated tap water. And one of the things that happened in the study that I'm reporting here is they used fluoride varnish twice a year in this study instead of 4 times a year. And what they found was that it had no decrease in caries incidence. So 2 times a year is not enough. You need to use it 4 times a year. So that's the answer, and that's been repeated in other studies as well. One of the other, I think, questions that certainly that we have on children is, at what age do you start using, fluoride toothpaste? They're getting exposure to fluoridated water typically in their community. At what age is it safe to start using fluoridated toothpaste, and at what level? And one of the challenges that you've got, and depending upon whether you want to follow the guidelines or the recommendations by the ADA or recommendations by the AAPD, one of the questions is, certainly if you start using fluoride on a child that's younger than 5, a standard 1,100 part per million fluoride dentifrice, you have the risk of fluorosis. It decreases their caries incidence, but it comes with an increased risk of fluorosis on those teeth. The question that you and the parent need to make the answer is, do the benefits outweigh the risk? And if the answer is yes, then I'd say use it. And if the answer is no, then I would say don't use it. But typically, in my mind, the benefit outweighs the risk. And there are some low fluoride or non-fluoride gels available to use on young children. The question is, they don't tend to work. They do reduce fluorosis, but they don't reduce the caries incidence. So you can go to a low fluoride toothpaste, but they really have no application in treating young kids. So they may reduce fluorosis risk, but they don't reduce the caries incidence. So in my mind, and this was a systematic review with a meta-analysis, there have been several papers published in the last year that all provide the same data here. So the answer on low fluoride toothpaste on young children is no, don't use it. And so it's really more of a dose threshold for fluorosis, and we'll talk about what dose then to use when that's age appropriate. And I'll do that as I go through the protocols here in just a few minutes. So standard fluoride toothpaste are effective in reducing dental caries in primary teeth, and they should be recommended for this group. It just, know that it comes with an increased risk of fluorosis. So you may want to show the parent and really look at the total fluoride exposure. Again, is the child living in suburbia? Do they have fluoridated water? I'm in Oregon. There are a lot of communities here that in the People's Republic of Oregon that do not have fluoridated water. I'm in a semi-rural community as well, so I have a lot of children in my practice that are on well water. So you want to make sure, but those children still get transported into the public school in town. Albany is fluoridated, so they're getting probably the majority of the drinking water during the day. It's probably fluoridated. So those are the kind of questions you need to really talk to the parent about when you kind of look at what kind of fluoride strategy you're going to create for the child. Are they drinking fluoridated water? Where are they consuming most of it? And I think it was just 2 years ago that the CDC, we reduced the fluoride in the water from 1 part per million down to 0.75 parts per million. So because of fluorosis as well. And we know that we get the same outcome with less risk for fluorosis. When we look at antimicrobial strategies, basically on children, you've got chlorhexidine, which had been the gold standard. I would tell you it's not the gold standard anymore. You've got betadine solution, betadine rinse, 10% povidone iodine, which I had tried on children for a couple of years. It actually works okay on children. It's just very problematic. Trying to get a child to rinse, somebody even at age 6, rinse with betadine once a month is a problem. And you could use it on a 2x2 and wipe their gums or wipe their teeth with it. But I got to tell you that most children let you do it one time, and they probably never get it in their mouth again. And then you've got sodium hypochlorite, like the CariFree treatment rinse. And there's some great research on using sodium hypochlorite as an antimicrobial agent and anti-plaque agent. I'll show you the research on that. But again, it's something that I would not give a child under the age of 6 anything to rinse with, because anything goes in the mouth, typically they swallow, and if it tastes bad, it comes back. They spit it out everywhere. But you could put it on a 2x2, or you could put a few drops of it on a toothbrush and use it that way on a child. Back in 2011, again, the ADA Council on Scientific Affairs looked at non-fluoride caries preventive agents, which, they looked at xylitol and chlorhexidine and the agents that were available to us. And one of the conclusions that came out of this was that xylitol chewing gum had weak evidence in older than 5-year-olds. It was an expert opinion in favor of all ages. Chlorhexidine thymol varnish every 3 months for root surface caries lesions on elderly patients had some evidence, but basically the conclusion was any other chlorhexidine in any form for any lesion site for any age in bold red letters was not recommended. So I really, if you're using chlorhexidine, I'd encourage you to re-examine your use of it in terms of treating dental caries. This was a study that Karen Hallett did again at Queensland in Australia. And they took 2 populations of high-risk children in different grade schools. So these were mixed dentition. They treated them over a period of 3 years. They used a 0.05% fluoride rinse on the placebo group, and they used the CariFree treatment rinse on the test group. The placebo group reduced their risk, or let's say the standard 0.05% fluoride rinse reduced their caries incidence by 29%, and the CariFree treatment rinse, just a 30-second rinse, every day at school. They're at school 4 days a week, 9 months out of the year, reduced the caries rate by 73%. And that occurred during the first 2 years. After the third year, there was no additional benefit in either of the two rinses. So that we know that this is about a 2-year project to modify the biofilm in the mouth. This paper was reported by Jorgen Slant's research group team there, and this was in December, and they looked at basically for periodontal disease, and he's been an advocate for a long time of using sodium hypochlorite, 0.2 or 0.25%, and here they use it just twice weekly, and it tremendously reduced the plaque indices on all surfaces of the teeth compared to the controls in the study. And so it's really an effective broad-spectrum antimicrobial agent that has very few adverse effects. The worst effect is that it doesn't taste very good. Other studies, we know that fluoride and xylitol together have synergistic inhibitory effects. Xylitol enhances the inhibitory effects of even very low concentrations of fluoride. So, I looked at strategies to include fluoride and xylitol all in one, maybe a pH strategy as well, like in the CTX3 rinse. So we know that xylitol has a number of benefits in terms of an anti-caries agent. We also know that pH strategies help modify the biofilm and should reduce the patient's caries risk as well. While we don't have a lot of evidence to report on that, at the same point in time, we know that pH is driving that disease and the selection pressure on the bacteria, and we know that that's how the body, stimulated saliva has an alkaline pH. That's how the body protects the teeth and creates homeostasis. So there are a lot of different strategies around that. One of them, of course, is like a spray or rinsing your mouth even with tap water. When we look at saliva, the things that we look at the risk factors in children, a higher salivary flow and an increased salivary pH are protective factors versus children that have a drier mouth or that have a lower resting pH of their saliva. They're at greater risk for dental caries. So that we know pH certainly plays, the amount of saliva they have and the pH certainly plays a role in this disease as a risk factor. Some of the things that we need to consider and continue to consider is the acidity in drinks. Water, I love this. This came out of the AGD back in January this year. Earlier, I thought it was a great visual. The problem is when we look at water on the far right at 7.0, that's tap water. About half of the water, bottled waters, have a pH of 7.0. About half the bottled waters have a pH of 4.0. So we need to make sure the patient is aware of, if you're drinking bottled water, there's no fluoride in it, number one, and number two, what's the pH of that water? Because if you're going to sip on that all day long. Probiotics, I always get asked about probiotics. This is a very nice review of probiotics published back in January in General Dentistry. My only problem with this paper is that they did not report a single negative outcome study, so that if you read the paper, they reported all these positive outcomes for probiotics in all different areas of medicine and dentistry and its use. The problem is it tended to lead you to believe that, probiotics work for literally everything and they're all positive, and when you really get down to the research on dental caries with a probiotic, I have a very hard time finding any paper that showed a positive outcome. So when we look at probiotics, they need to be live bacteria, they need to become a permanent member of the biofilm, and they need to then provide some outcome, and they need to work on the high caries risk population. So when you look for a study that has all of those elements in it, they're hard to find. And if you find those studies, you find that they don't have a positive outcome. Here they use Bifidobacterium animalis. They administered it to kids at a very young age, and then they looked at it at age 4, and what they found was it didn't become a permanent member of the biofilm in the mouth, and there was no net effect on the caries incidence of that population. Again, this next study was looking at Lactobacillus KCI, and it was the strain LF19. And the same thing, they looked at these children again at age 9, and same results. They administered 179 children from the age of 4 to 13 months. They gave it to them every day. They looked at them 9 years later, and they found, again, it wasn't present at all. It had no effect on the frequency of caries on the mutants, streptococci, or lactobacillus. So it's like there was not a positive outcome. So I tell dentists, if you want to try probiotic supplements, try it, but just don't depend on that as your only strategy. You know, I think they're interesting. I'm still hopeful that we're going to, find a probiotic that will work for dental caries. But as of this webinar, I would tell you I can't name one. So that has any of those, all of those attributes. So if you are aware of one, I'd certainly appreciate you sharing that with me. But again, it has to meet those criteria. When we talk about behavioral change, then we're really talking about wellness coaching and how do you help patients modify their behavior. When I look at what things are potentially modifiable, number one, sticks out as diet. Certainly, the increase for children, the increase of sugar intake, and this was a study that kind of I think surprised me, only from the standpoint of the results of the study when reading the entire study were that a lot of children are eating sweetened breakfast cereal for dinner. Not only do they have it for breakfast, but that's their dinner at night. And I don't tend to think that that's what's happening in our society, but in reality is they're eating a lot of sugar during the day, and they may be flushing that down with a Coca-Cola or a Mountain Dew or something at dinner time as well. So we have those kind of issues going on. No matter how well we try to modify the diet in the schools or try and get some of the vending machines that have some of those food selections out of the schools, certainly this is an issue, for all for all segments of our population. So sugar in dental caries is an issue. Sweetened beverages, I thought this was quite an interesting study. This one was just published. And looking at when did children get sweetened beverages, and something that we need to be aware of, but I thought it was very interesting. I'm a grandparent myself. Dan and I have 9 grandchildren, and family influences such as grandparents increase the children's consumption of sweet drinks. And I mean, as a grandparent, you're always, whether it's soup, fruit juice, or soft drinks, and regardless of parental disapproval, and I can tell you that happens. It happens in my own household. It's like my grandson says, "Hey, can I have this?" Sure. You know what? You can have that. It's not going to kill you. I know your parents don't let you have it, but hey, that's my role as a grandparent, right? But it's interesting to look at. Children were often given this as a reward, or when they're out for good behavior, when they're out shopping with their mom. And I remember getting that reward myself. If I was really well behaved in the grocery store, I got a treat, and it was typically something that was really sweet. Or when they're out to dinner or at dinner parties. So we look at sugar-sweetened beverages with children, and there tend to be patterns in behavior there, and things that we can help the parent become aware of. Have a really interrogation session with the grandparent, I think, maybe. The uptake of toothbrushing. This is a study that there haven't been a lot of studies, and Alice Horowitz did these studies back in the 70s and found that there just was really no good correlation in population studies between oral hygiene, toothbrushing and flossing, and incidence of dental caries. And they conducted those studies in the school, so it was supervised brushing as well. But so that's kind of discouraging for us in the profession, because we really think, if you brush and floss and you eat right, you're not going to get any tooth decay. Take care of yourself, do everything right, you should be healthy. When we don't really have a lot of data that proves that. We are getting some studies. There was a study published last year demonstrating the benefits of flossing. But this was a study that was done in Scotland, and there were 99,000 children at age 5, and they looked at them over a 12-year study in actually teaching a child how to brush their teeth in nursery school and preschool, reduced the DMFT scores in the population from 3 to basically 2. I mean, cut it by a third, just teaching them how to brush their teeth in nursery school or in primary school. So preschool. So I think that's a really strong study, and there were 99,000 children in that study. So it's a huge cohort here. When we talk about wellness coaching for sustainable behavioral change, anybody can change a habit in 28 days, but 4 days later it's gone if they don't have continual reinforcement. So those are the things that we kind of need to be aware of, and people don't tend to make a lot of changes at one time. We're best when we're focusing on changing one behavior at a time, not 4 or 5. And I'll see Carrie's strategy plans where the hygienist has written up 15 different things they want the patient to start doing, at like 8 different times during the day, and it's like, that is never going to happen. That's not human behavior. It's not how it works. We're lucky if we get them to make one change, and we can help them make that consistently. So it's really important you identify the most important factors, risk factors the patient has, and in the wellness coaching model, it would, we would tell you, let the patient decide which one to work on first, right? If they have 3 things they need to change, let them decide, because that's the one they're most interested in and going to be most likely to be successful at. That will give them the opportunity to help them with the next ones as it comes. But patient-centered, basically this is wellness coaching, working with the patient, helping them identify the problems, and having them come up with the treatment strategies and really have input on how they're going to do that. How are they going to solve it? What is their plan to make that happen? Instead of me telling them how often they need to brush their teeth every day, they need to tell me their plan on how they're going to successfully do that every day and remember to do that. And then this paper was just published, and I thought it was interesting. In this study, they looked at motivational programs on children and found that it died without constant reinforcement. Like the child needs to have positive reinforcement every day to change and create a new habit that's sustainable. So the studies coming out of some of the wellness research indicates, certainly the Cleveland Clinic indicates it takes up to 9 months of constant reinforcement to create a new habit that's sustainable. So this isn't the old, do this for 4 weeks and you'll have a new habit. This is really a matter of this is going to take 9 months or longer, and it really needs continual reinforcement. So when we look at the Pediatric Protocol, we've talked about all kinds of different strategies and therapeutics there tonight. Certainly I utilize these, the CariFree products, rinses, gels, with or without fluoride, fluoride varnish, sprays that elevate the pH, xylitol lollipops, we have those available. So let's talk about your specific children, 0 to age 5. These are the youngest children in your practice. You need to do a caries risk assessment on every one of them. In my mind, you need to use the caries screen and do the ATP. It gives you a baseline, tells you about bacterial load, tells you whether or not this patient would benefit from any kind of antimicrobial strategy. I don't think we need to go over, what's an appropriate diet and what are best home care recommendations. I think we all know that inside and out. You may want to swab their teeth with an antimicrobial agent. That's an option. If they had a high ATP score, they had a lot of visible plaque on their teeth. Certainly and always is fluoride varnish every 3 months, and every kid, high-risk kid in my practice gets that. Every child gets it every time they get their teeth cleaned. So even for the children and adults that come in once a year or twice a year to have a prophy, they get a fluoride varnish in our practice. Then we're talking about the fluoride 1100 part per million, that's standard toothpaste dentifrice level, over the counter. We have that in the CTX 4 gel. And if you are talking about a child, if you want to use that on a child age 0 to 3, we're talking about a dose that's the size of a grain of rice, a white grain of rice. So it's very tiny. That's going to help reduce the amount of risk for fluorosis. If they're age 4 to 5, you can start to use, a larger amount, more like a green pea. You never use more than, on any of these gels, you never use more than the size of a green pea. And you may even want to show the patient what that looks like on a toothbrush. Here's a grain of rice, here's a green pea. And because obviously, when they're under 5, typically the parent's going to be helping them brush their teeth. And then you may want to use, optional other strategies like a spray or lollies as a reward instead of a sugar-sweetened beverage. If the child is age 6 and older, again, caries risk assessment. I'm going to always do a caries screen at least once a year. Same recommendations, routine diet and home care recommendations. You know what those are. Fluoride varnish every 3 months. Antimicrobial rinse. Here we get to the CTX4 treatment rinse. That's an option. If they've got a high ATP score or, high bacterial load, that's something that you may want to discuss with the patient and the parent. And it may be that they have, again, high caries risk, but they don't have a bacterial issue. It may be just a dietary issue, or it may be a medication-related issue and an amount of saliva they have, or maybe even a genetic issue that I've identified on several patients. So that, if it's appropriate, you can use it or not use it. Certainly you can go from 1,100 up to 5,000 part per million in this age bracket. But again, we're talking about a pea-sized amount on their brush, and I would have them use that twice a day. And you may use another option is 0.05% fluoride rinse, and if you had the patient use that, I'd have them use it just once a day at night. So those are kind of your protocols. They're fairly simple. I don't want to make them complex. And if you've got a number of different things you want to try with the patient, start with trying to help them change one thing at a time, whether it's diet or home care. Have the patient, identify where they want. Ask them, where would you like to start? What would you like to work on first? Here's all the things that we need to solve over the next couple of years. Where do you want to start, and how would you solve it? Tell me your plan to make that work and to accomplish that. So that's kind of the pediatric patient. The orthodontic patient isn't a whole lot different. I'm going to go through that quickly here. Basically, we're talking about dental caries risk on the orthodontic patient with the fixed orthodontic appliances, and the biggest one is the white spot lesion risk. So this is a paper that was just published last year, looking at caries risk assessment should be a part of every initial evaluation for an orthodontic patient. If they're at high caries risk, they're going to get lesions. They're going to probably develop white spot lesions as well. And when I sit and talk to orthodontists, the biggest headache they have is not relapse. When I was, 30 years ago, everybody didn't want to talk about relapse. Today, everybody doesn't want to talk about white spot lesions, and that's the biggest headache that they have in their practice. And they can be eliminated. They can, certainly make it manageable just by doing a risk assessment. You could do the risk assessment. I could tell you with pretty good predictability who was going to be at risk for those and who wasn't. And we're going to talk about those individual risk factors here in a second. Again, the ATP Bioluminescence, there were a number of studies published and done by graduate students at Oregon Health Sciences University looking at ATP as it correlates to orthodontic patients in terms of being able to predict bacterial load level, oral streptococci level, and basically even using it to check their oral hygiene during orthodontic treatment as well. So if I were an orthodontist, I would have one of these meters. I would use it on every patient. I would probably use it at least twice a year on those patients just to continue to look at my baseline. This was a very interesting study. There were I threw it out here tonight because I thought it was very interesting. They were adolescents 15 to 16 years of age. There were 104 in the test group and 111 in the control group. And what they looked at was after the treatment was over, looked at patients that didn't have orthodontic treatment and found that patients that had undergone orthodontic treatment over this period of time actually had fewer carious lesions than people who hadn't had orthodontic appliances. So I think we all tend to think of orthodontic appliances as increasing your caries risk, and here was the opposite outcome. They actually had fewer lesions, and so the question is, well, why is that? And the authors actually discussed it and said it may be a result of their heightened awareness for diet and oral hygiene while they're wearing the orthodontic brackets may actually, reduce their caries risk because they're more focused on their oral hygiene typically. So anyway, they had fewer lesions, and I thought that was an interesting report to study, an interesting study to report, pardon me. I thought this was an interesting study as well. They actually looked at, after the orthodontic appliances were taken off, how did that affect the biofilm in the mouth? And I think the scary thing for us was, certainly at time period 4, which I believe was like 13 weeks, significantly there was an overall reduction of biofilm in their mouth, but within the biofilm itself, the number of strep mutans and strep sobrinus increased significantly. And so, it doesn't end after orthodontic treatment. That has changed the biofilm in the process, and these patients may become at higher risk for dental caries based on the microbiology. So it's certainly something that we should be aware of. And then the white spot lesions, and this is a paper that was just published this year, and I like this paper because it really went through what are the specific risk factors that correlate to white spot lesion risk. And the number one of those is poor oral hygiene. Number one is poor oral hygiene. That was the highest risk, but males were high on the list, and that was actually a risk factor. Males had significantly more white spot lesions than females. Poor oral hygiene males, increased treatment time, lack of the use of fluoride supplements, and then sugary foods and sugary drinks. So, I mean, these are kind of logical things, and the interesting thing was they looked at then also which teeth had the highest risk of white spot lesions, and it was the maxillary canines and lateral incisors, and the mandibular premolars and first molars, and it was typically the gingival areas that were at greater risk than the incisal or occlusal areas. So I thought that it was just a really good identification of what these risk factors look like in that orthodontic population, because again, we can use these to start to screen patients and say you're going to be at greater risk, and we know what helps or what tends to increase white spot lesion incidence in patients. So what do we do about it? Well, early studies by John Featherstone indicated just using a 0.05% fluoride rinse once a day would virtually eliminate all white spot lesions while patients are undergoing orthodontic care. There have been a number of papers published using a high fluoride toothpaste, 5,000 parts per million versus 1,100 or 1,400, resulted in a 32% reduction in white spot lesions. So certainly a 5,000 part per million fluoride gel with high pH and xylitol, I think, would be a good strategy for these patients. One of the things, looking at the Cochrane database, the systematic reviews, certainly there's a tremendous amount of evidence indicating we should use fluoride on our orthodontic patients. There's not a tremendous amount of evidence to say which type of application is best, but certainly one that there's been a lot of research on, and certainly should be an option for your patients is a 0.05% sodium fluoride mouth rinse. So for my orthodontic patients, those are something that I would probably recommend as well. So on that orthodontic patient protocol, every orthodontic patient I have gets a caries risk assessment. I would use a caries screen, and again, I'm screening out those patients. If they're high, have a high caries screen, or have active lesions, they're not getting bracketed. Those patients need to get, a healthy mouth before you put them into orthodontic care, or their unhealthy mouth is probably going to get more unhealthy during that treatment time. Again, diet and home care recommendations, particularly increased oral hygiene recommendations, and brushing techniques to make sure they get those gingival areas really well. Fluoride varnish every 3 months. I mean, that's an always. I would recommend all the patients use a 5,000 part per million gel, dentifrice twice a day, and then I would have them on a 0.05% fluoride rinse once at night. And that should really help reduce the risk of white spot lesions and also dental caries during their treatment. So that really concludes tonight. We went through a lot of material. We made that in just 62 minutes, which I'm pleased. But we do have time for a couple of questions here. Janelle, so
yeah,
fire away.
Great. So thank you, Dr. Cooch. We have some really great questions coming in. I know you touched on a couple of these already, but I think they're still great questions. So the first one, I noticed the biofilm challenge is optional for ages 0 through 5 on the CRA form. At what point would you use the caries screen meter on a pediatric patient?
I would use it as soon as their teeth erupt. So as soon as I had, 6 teeth in the mouth, and even a couple of 3 or 4 teeth, I would definitely use the meter. I use it on all of my patients. So I would start as soon as we have teeth erupted. So probably somewhere around age 1, 1.5, I'd start testing those teeth. Okay. And it's probably a good idea, Janelle, and probably a good idea to test mom. If you're not, be testing mom. If mom has a really high, off-the-chart ATP score, we got a bacterial problem that's going to get transferred to the child. So it's like, it might be as important at that age in the first couple of years of life to test mom as it is to test the child. But so I would test both, but that happens in my practice. So great question.
Yeah, that's a really great point. So second question, using the caries screen meter, would you use the same data threshold to assess a pediatric patient as an adult patient?
That's another really good question, and I would say yes. My short answer to that would be yes. The data that we got from OHSU really, we created those parameters from low risk to moderate and high risk based on adults and children. So I would use that same 1,500 relative light unit cutoff for children as I do for adults. And that's my short. Without going into great detail, that would be my answer. The answer is yes.
Perfect. Next question is, what is your antimicrobial recommendation for a high-risk child under age 6?
So, that's another really good question, and I covered that a little bit tonight. Fluoride does have some antimicrobial properties. It does reduce acid production, and it does interfere with their metabolism. So certainly the fluoride varnish, in my mind, has some antimicrobial properties. So every 3 months using fluoride varnish isn't always. If you want to talk about strictly an antimicrobial agent like either povidone or chlorhexidine or sodium hypochlorite, my recommendation would be for that child, I'm not going to give them something to rinse with. I'd either, if they're really young, let's say age 2.5 and below, or let's say that 0 to 3 age, I'm going to put it on a swab and put it on a 2x2 or something and wipe their teeth with it or wipe their mouth with it. And if they're a little older, than they're say age 4 or 5, and I wanted to use an antimicrobial agent, I would put a couple of drops on their toothbrush and brush their teeth with it, and then have rinse their mouth and stuff out when we were done. So that would kind of be my approach. It's tricky when you start trying to do antimicrobial agents on children under the age of 6, because everything you put in their mouth goes down the gullet. So, and we really just don't need to have them swallowing that. So that's kind of would be my best approach for that. That's a really good question.
Great. I think we have time for just one more question, and that is for an orthodontic patient with active carious lesions. Would you recommend waiting until ortho is completed before starting caries treatment of any sort?
I want to make sure I understood the question right. So the orthodontic patient with active carious lesions, would I wait until after the ortho before I started the caries treatment? Did I get that right?
Correct.
I think that's actually the reverse is true. For a patient with active carious lesions, I wouldn't start the orthodontics until I had the patient healthy. And number 2, if I saw a patient that came to my practice and they were undergoing orthodontic treatment and they had active carious lesions, I would start on it absolutely as soon as possible. They get a fluoride varnish before they left the office that day if I didn't do anything else. So if you've got a patient that's got fixed orthodontic appliances on them and they come to you and they have carious lesions, don't wait. Have them take the arch wires out if they're interproximal lesions. They need to be restored. Get on that as quick as you can, because leaving that person with that environment in their mouth is a recipe for disaster. So whatever they're carried, treat them like you just would, whether the orthodontic appliances are present or not present. Treat that patient from a caries standpoint like you would. And I would, any patient that comes in that has active carious lesion gets immediately put into the caries treatment in my practice, which includes all of those therapeutics, right, identifying the risk factors and then treating those, targeting those specifically, and or restoring whatever lesions that need to be restored, and or remineralizing ones that we can remineralize. And for that orthodontic patient, like I say, if that requires taking the arch wire off to get to those lesions, take it off. I mean, get in there as soon as you can. But literally, I think my goal, my dream for orthodontists would be able to screen and identify those patients before you ever put the fixed appliances on. And I think that we're really at a point in time where they should, with a pretty good degree of predictability, be able to do that, and then certainly monitor the bacterial load and things while they're going through treatment. If I saw a patient that was developing white spot lesions, I would immediately start treating the white spot lesions as that person is high risk immediately. Don't delay, or you're just going to end up with more issues for the patient. That's a really good question, Janelle.
Great. Well, thank you, Dr. Cooch, and thank you to everyone for all of your great questions. Again, any of those that were not answered by Dr. Cooch will be answered via email within the next few days. And also an email will be sent out tomorrow with a link to the recording for anyone who wants to share this webinar with their staff. Please feel free to contact us with any questions. And if you want to learn more about implementing CAMBRA in your practice, again, we do offer one-on-one webinars, and we'd be happy to schedule one with your team. So thanks again to everyone, and have a great night.
Thank you, everybody. I enjoyed the webinar, and I look forward to seeing you all next time. Good night.